So the case that we're going to talk about today is a patient who was diagnosed in 2016. She's a 58-year young female who's diagnosed in 2014. She's a 58-year young female diagnosed in 2014 with stage 4 ovarian carcinoma, period. Her final pathology was a high-grade serous carcinoma from epithelial ovarian cancer. Her initial CA-125 was about 460 upon presentation. The CAT scan that was obtained prior to surgery, it was a CT scan of the abdomen, pelvis, and chest, which revealed a 4-centimeter mass of the left ovary, peritoneal carcinomatosis, and some ascites. She underwent surgery, it included exploratory laparotomy. She was suboptimally debulked with residual disease greater than 1.5 centimeters. Postoperatively, the patient received combination intravenous intraperitoneal chemotherapy with carboplatin and paclitaxel for 6 cycles. She achieved a complete remission with a normalization of her CA-125, CT scans, and physical examination. Approximately 2 years later, in 2016, she had some symptoms of recurrence, some bloating, and some early satiety. Her CA-125 had risen to 255. She had an ECOG status of 1. At that point, the decision was made for the patient to be treated with chemotherapy. She was treated with carboplatin and paclitaxel for 6 cycles, along with bevacizumab. She had a good partial response at that time and went into remission. She had a good partial response at that time with a CA-125 of 45, and she continued on bevacizumab maintenance. About a year and a half following the second-line chemotherapy, we're now into 2017. She again presented with symptoms of early satiety and bloating, as well as some pelvic discomfort. Her CA-125 had risen to 515, and she had an ECOG status of 0. Genetic testing at the time was noted to be germline BRCA1 and 2 wild type. Currently, the patient has a CA-125 of 620. Her CT scan shows several small masses within the lung, as well as abdomen, and she has an excellent functional status of ECOG of 0. What I would say is this is somebody that's typical that we see with ovarian cancer. This is a young woman who developed some symptoms of ovarian cancer and then unfortunately presented with that advanced stage disease where she had stage 4 disease based off not just her CT scan findings of abdominal disease, but pleural effusions or something within the liver parenchyma or upper abdomen, such as a pleural effusion. When we see young women like this that have a really good functional status, I like how they treated her. They treated her very aggressively and took her for primary surgical site of reduction, which again, candidates for patients with stage 4 at this point, a lot of people would consider neoadjuvant chemotherapy, which is 3 cycles of chemotherapy, interval debulking surgery, and then 3 to 4 additional cycles of chemotherapy, and then consider maintenance therapy up front. This patient was treated aggressively with upfront surgical debulking. Unfortunately, she was suboptimally debulked, which meant that the disease that was left was greater than 1 centimeter, and a lot of folks would consider any gross residual disease to be suboptimal. So I think this case brings up a couple points. One, should she have had a primary debulking? It sounds to me like the surgeons felt that they could get everything, so they did their best too. And then two, with that neoadjuvant chemotherapy, should she get 3 cycles or 4 cycles and then interval debulking? And most people would say 3 cycles of chemotherapy and then interval debulking, followed by additional chemotherapy. So again, I think that in 2019, we have lots of options for these patients. It's really about how functional the patient is, what the risks the patient really wants to take, and then what the surgical skill and what they're willing to risk for trying to do a primary surgical site of reduction. In my opinion, to take somebody to the operating room, I would try to get that patient to microscopic residuals. So to me, to do a laparotomy, realize you may not be able to get the patient to a complete surgical site reduction. Maybe abandoning that, giving him chemotherapy could have been a choice. But I think what they did was completely fine. I think the other thing that was outside of the kind of new wave thinking is giving somebody combination IV-IP chemotherapy who is suboptimally debulked. Most of the studies that we've done looking at in the United States, it was patients who had gross residual disease of less than 1 centimeter. GOG 252 was the most recent trial that really showed marked improvements in progression-free survival in the 26, 27, 28-month range, which was a combination of aggressive surgery, combination IV-IP chemotherapy in 2 arms, and then weekly IV chemotherapy in 1 arm, and then placing the patients on maintenance bevacizumab. But I think what we can say is that this patient was treated very aggressively with primary debulking surgery, given combination IV-IP chemotherapy to achieve remission. And again, she did that. She is like what we consider 80 to 90% of folks who come in with this new diagnosis that will achieve remission, which again, remission defined as normal CA-125, normal physical examination, and normal imaging studies such as a CAT scan. So I think that this was a very well aggressively managed patient up front.